Good afternoon, everybody. My name is Claire Stevens, so I'm a GP, the cancer lead for the STP, and also the co-clinical director of the Cancer Alliance. And I've got with me today some colleagues from our local hospitals who are going to talk to us about CUP and GI and colorectal issues. So thanks very much for coming today. Just a little bit about who the Alliance is. So the North Central London Cancer Alliance is one of the 21 cancer alliances in England, and we're focused on meeting the national targets for early diagnosis and treatment. We're involved in developing pathways, supporting research and development, and championing innovation in practice. We cover all the boroughs of NCL, and you are our partners, as well as commissioners, councillors and charities, hospital trusts, and of course patients. What we're here to do, we're an NHS organisation, but what we're here to do is to transform and improve healthcare strategy and ensure that we support the prevention, diagnosis and treatment of cancer for our local population. We're interested in reducing variation and levelling performance up so that we improve our 1 and 5 year survival rates. So I've got with me today Ed Seaward. You'll recognise some of these names, I know. Ed Seaward, Chetan Barn, Khurram Khan, Manish Chand, and also Catherine Nestor and Vanessa Ponsumami from the Alliance, who are helping put on the webinar today. We'll be running for an hour until 1:30. We'll finish promptly, and what we're going to do is go through our speakers and let them, I think, answer. I'll let you answer a few questions, ask a few questions through the talk. Catherine will collect them and we'll share them and answer them if we can through the different presentations, and then I'll try to run it so that we have some extra time at the end for some final questions. So this is slightly different, although you've accessed it from your Microsoft Teams invite. The platform is a little bit different. You need to pop your questions in the chat. We'll pick them up, and then we'll be able to talk to answer those questions. But what you can't do is speak live live during the meeting. It's just the platform that we're using today. But thank you very much for attending. So I'm only going to show one extra slide, which some of you may have seen before when I've spoken at Joe's webinar, and it's around, but it's got updated data on it. It's around our shortfall in cancer diagnosis as a result of COVID. And that yellow area coloured in on the graph, that thanks very much for showing that, is showing us around about just over 900 shortfall in first treatments for cancer. So that's a proxy for saying we're missing about 900 cancer diagnoses compared to this time last year, which is really significant. And the situation is at this moment worsening, not improving. So from a primary care perspective, the challenge that faces us is trying to ensure that we keep all the techniques that we normally use for promoting early diagnosis up and running, despite that we're also madly trying to vaccinate and carry on business as usual. Be aware that patients are finding it difficult to contact us, and a whole section of patients are trying to defer talking to us at all about their anxieties, and that comes from a mixture of different things. We know from research we've done and questionnaires that we've done in patients over the last few months that a significant proportion, more than 50% of people who are having symptoms are choosing not to contact us because they feel that they don't want to put more burden on us. So we're trying to use lots of different mechanisms to reach out to patients, to tell them that the NHS is open and they need to come back and tell us about their health issues. And from our perspective as GPs, we need to be driving them through the cancer diagnosis pathways when appropriate, and assuring them that their risk of catching COVID when they attend outpatient appointments is minimal, is less than going to the supermarket actually, because the hospital environments are so controlled. Okay, so I'm going to pass on now to Ed Seaward. So Ed's a gastroenterologist. He's spoken to GPs in NCL lots of times before. He's led our work on FIT and the introduction. I've worked closely with him on that. So I'm going to let, good afternoon, Ed, you want to give yourself a little bit of an introduction and explain what you do. Thanks very much for coming today. Can't hear you at the moment. You're on, that's it. I think
there we go. Yeah,
that's it.
Brilliant. Thanks very much for having me today, Claire. I have only just mastered this in the last couple of minutes, using this platform. But Catherine, are you driving my slides, or is it Vanessa? Okay, so we'll go on to the next slide, please. So as you've heard, I'm a gastroenterologist, and my primary interest has been sort of pathways of care, and in particular use of FIT. So this is actually a nice segue from Claire's slide, which basically shows the same thing. So these are lower GI referrals in 2019 in the blue line versus 2020 in the orange line, and we took a big hit on the first wave. And just to highlight what Claire said, nationally there was a 73% reduction in diagnosed use of colorectal cancer across the UK in the first wave, and clearly this is the reason why, is that patients aren't coming to see their GPs, and that's going to be a problem. Next slide. And more sort of gloom. Across NCL, we've had a reduction in our diagnostic capacity, specifically at UCLH. We've been picking up more specialist endoscopic work from other hospitals, so we've been busy doing that. There's all sorts of rigorous infection control requirements, lots of patients anxious about attending hospitals, and currently I have 2,500 patients sat on my waiting list, which is a bad situation to be in. Next slide. It's not all doom and gloom. We are able to open on the weekends. I was just chatting to Chet before we did this talk, and one thing that's been really exciting for me is actually we are working much better, first across NCL, and also I would like to think between secondary care and primary care. So I think there are benefits to all of this. We've got some new technologies. So we're using Cytosponge, which is this sort of capsule on a pill that you capsule on a thread that you swallow, and you drag it through your esophagus to look for dysplastic cells, and that's meaning we're having to do less upper GI endoscopy. We've got colon capsule, which I would love to talk about really in its own particular session, because that allows us to perform lower GI diagnostics in the patient's home, which is really exciting. We've got FIT, which I'm going to talk about. There's predictive tools for upper GI cancer that we're using. I was asked to mention Bowel Scope. So Bowel Scope is now finished. So for those of you who are less aware, this was the process where 55-year-olds were invited for a flexible sigmoidoscopy, and we're able to pick up polyps on that, which was demonstrated to reduce your long-term cancer risk, even though it's just a limited examination. It's a great idea. The data behind it is very good, but it's incredibly demanding in terms of its demands on capacity. So rightly, there's been a national decision to can Bowel Scope, but what they're going to do instead is to try and age extend bowel cancer screening. So in England and Wales, bowel cancer screening starts at 60. The plan is to get that down to 50. And so that's really exciting, and obviously that's a challenge because it's another challenge for our capacity, but it's still, I think, the right way to go in terms of reducing the risk of bowel cancer in the future for our populations. Next slide. So I'm going to talk a little bit about FIT. So this is an antibody against the globin portion of the hemoglobin molecule, and that contrasts with FOB testing, which detects the heme molecule. And heme is non-specific. It's shared amongst mammalian groups, whereas globin is specific to humans. And so FIT is, number one, it's much more sensitive and much more specific than FOB testing. It's also much more sensitive and specific than symptoms are in terms of predicting the risk of colorectal cancer. It's a very easy test to use, which helps with compliance, and it's quantitative, and that's really important. So it gives you a number, and because it gives you a number, you can decide at which point you're going to intervene. And in symptomatic patients, and I'll show you the data for this in a second, we say that if your FIT is 10 or higher, then that requires investigation. In bowel cancer screening, and this is a really important point that often people don't appreciate, the FIT level that you get a colonoscopy in is 120 in England. It's actually a lot lower in Scotland, it's 80. So if you ever see a patient who's had a negative FIT test as part of bowel cancer screening, don't get reassurance from that. It doesn't mean it's less than 10. It means it's less than 120. So it can still be really high. And that's really important to remember. And then one other important point I wanted to make about FIT is that globin is broken down in your upper gut. So if you have, often I get asked by non-FIT interested people, if the FIT is positive and the colonoscopy is normal, do I need to do an OGD? You don't. It's not like iron deficiency anemia. So don't worry about the upper gut. Next slide, please. So what's the data? So we did the QFIT study across NCL mostly. So that was 3,500 patients, and we diagnosed about 100 colorectal cancers in that group. And next slide, please. And if perfect. And essentially, in the red boxes, we're looking at negative predictive value. Exactly. So if your FIT is less than 10, you have a 99.5% chance you don't have bowel cancer. So it's a really good test. If your FIT is less than 10, and 80% of patients on a 2-week wait pathway will have a FIT less than 10. So that's worth remembering. If your FIT is greater than 10, and I'm moving across the right-hand side of the graph now, you have a 9.7, let's call it 10%, a 10% risk of colorectal cancer. And the higher your FIT is, the greater the risk of pathology. So if your FIT is greater than 120, you have a 23% risk, let's call it a 25% risk of having bowel cancer. So those are really important learning points. FIT less than 10, your risk of colorectal cancer is 0.5%. It's really low. If your FIT is greater than 10, your risk is 10%. And the higher that FIT number comes back, the greater your risk of having bowel cancer is. Now that contrasts, before we brought FIT in, the pickup at UCLH for colorectal cancer was 2.5% on the 2-week wait pathway. So in other words, symptoms alone. So symptoms are rubbish. FIT is a much better way of predicting who's got cancer and who hasn't. Next slide. So there you go. That summarizes just what I've said. Now it's important to talk about FIT negative cancers. Now, of those 100 cancers that we had in the QFIT study, 15 of them had negative FITs. So it's possible to have a negative FIT and to have colorectal cancer, and there are a whole bunch of reasons why. But the honest answer is nobody really knows. But surprise, surprise, no test is 100% accurate. We know that from every aspect of medicine. We know that if you exclude iron deficiency anemia, this halves the risk of diagnosing a FIT negative cancer. So if you can exclude iron deficiency anemia and say, look, we're going to investigate those patients anyway, we're not going to trust the FIT result because the FIT is unreliable in the presence of anemia, then you approximately halve your risk of missing a colorectal cancer. So again, that's another really important point. Next slide, please. Now, these next two slides are going to be really busy. On the left-hand side, this is the new 2-week wait pathway, which is artfully color-coded into basically red, yellow, and green. On the red side is your standard NG12 patients. So hopefully everyone knows what that means. So that's, it's the usual bunch of symptoms that would normally trigger a 2-week wait referral. The yellow bit in the middle, that's patients with weight loss, but with no definite GI symptoms. And basically you can kind of lump those into NG12 patients. They're no different. The green pathway is DG30 patients. Now, you'll remember that DG30 was a pathway designed for people with low risk, but not no risk of colorectal cancer. And these patients, NICE asked primary care to do fit testing on, and if the fit was positive, then you refer them up on a 2-week wait pathway. If the fit is negative, then you safety net them in primary care. And that pathway stays as it always has done. So I'm going to be talking about the red and the yellow pathway. So what you do, you have your patient with NG12 patients symptoms in front of you, and you do a fit test. There are exclusion criteria, and that's in the white box below the big red box, which is if they have really obvious symptoms or signs of cancer, so they have a rectal mass or anal ulceration, or if they've got iron deficiency anemia, then you refer them anyway. You know, the risk of cancer is really high. Nobody wants to run the risk of having a false negative fit. You just refer them on a 2-week wait pathway. Everyone else, you do a fit test. If the fit is greater than 10, you refer them up on a 2-week wait pathway, as you have been doing. And if we flip to the next slide, because that shows then the bottom half of the pathway. So if your fit is greater than 10, you refer them on a 2-week wait pathway. They get a colonoscopy or they get a CT colonography, and they get managed in the usual way. If the fit is less than 10, then we jump to the blue pathway. Now, this blue pathway has been approved by CAG, and it's for evaluation of the 2-week wait pathway. Hey, have I dropped out?
Fine, we can. Yeah. You haven't dropped out. We can see you.
Oh, brilliant! Sorry, my computer did something funny. If the fit is less than 10, then they're going to be referred up on this new pathway, which is being evaluated. And essentially, what they do is they're going to be safety netted in secondary care. So you do a referral saying, I've got this guy with NG12 symptoms, his fit is less than 10, therefore his risk of colorectal cancer is really low. You refer them up on the fit less than 10 pathway, and then they will see a senior clinical decision maker, which is going to be a consultant or a senior SPR. Usually, well, face-to-face is a decision that's been made at UCL, but it might vary across NCL. And they will have an appointment. They have a repeat fit test to see if that's changed. They have a repeat full blood count to see if they developed anemia or not, which is obviously a high risk feature. And then a decision is made about what to do with that patient. And it might be they say, you've had 2 consecutive negative fits, your symptoms all sound a bit IBS-y to us, or you've recently started metformin and we're going to blame that, or you've got a bit of bright red PR bleeding and we've examined you and you've clearly got big piles. We're going to sort that out for you. And then we're going to discharge you back to your GP. You do not have colorectal cancer. Or they're going to say, actually, you do have worrying symptoms. I know the fit's negative, but I'm also aware that there is a low risk of there being a fit negative cancer. I'm going to investigate you appropriately. So there's basically a variety of options open to us where we can get these patients managed. And as I say, this is going to be evaluated as a pathway, and conclusions are going to be drawn over 12 months, and then we're going to feed those back, and that's going to inform the pathway going forward. So hopefully we'll know what to do. Next slide, please. And actually, if we jump on to the next slide, I just wanted to show, unfortunately, I've lost view of what you can see now, but hopefully it says our current compliance. So this was a audit that I did with a couple of medical students back end of last year, and basically showing that use of fit had gone really well on a 2-week wait pathway. So 3/4 of our patients were having fit tests, which was great. A quarter weren't, which is less good. Now, the main problem for me is that 2/3 of the referrals had a positive fit greater than 10. A third of them were being referred up with a negative fit. These are people with a 0.5% risk of colorectal cancer, and these are the patients under the new pathway we're going to manage differently. And so if we go on to my next slide, please, issues to remember, it's really just to highlight that FIT is a great test. It's a really good test. It's not perfect, but it's a really good test. What I need, my big plea at the moment for use of FIT is that we're having a lot of patients referred up who don't have NG12 symptoms, mostly because they're not age compliant. So doing a FIT on a 19-year-old with diarrhea and say a positive calprotectin is really not helpful, because then they end up on a cancer pathway, and that generates a lot of anxiety for the patient and potentially a lot of anxiety for me too. So it's really remembering that you have to have the symptoms, the NG12 compliant symptoms, plus a positive FIT to be referred up. And then just one final, the top point I put in there is that if you've got patients at home who don't want to come up to hospital, but they have lower GI symptoms, we now are able to investigate them with colon capsules. So we can deliver it all at home like an Amazon parcel, and the patient can be investigated in the comfort of their own home. So if they're anxious about coming up to hospital, we can get them investigated, and that's a big step forward. Final slide. That's all I was going to say today. I'd welcome any questions about anything I've talked about. Thank you very much.
Thanks very much, Ed. That's really interesting and great to know about the colon capsule. So I've got one question I know lots of people are wanting to ask, which is how can they describe to you that they need a colon capsule investigation, and what level of capacity have you got regarding colon capsules? Are there lots of them in the storeroom or not that many?
So there is there's an NHS England programme which is been set off to try and look at the use of colon capsule, and we've got, in terms of capacity at UCLH, we can do 15 a week, which probably doesn't sound very many, but that's 3 colonoscopy lists a week, so it's not bad. And there's also the service which has been set up and running for ages at Royal Free, and the Whittington are also setting up as well. So it is a pan-NCL service. Particularly if you have a patient in mind, the easiest thing probably is to write to me or email me or something, and I can sort it out. But doing a FIT on those patients would be really helpful as well, because that allows us to triage their risk.
Yeah, thank you. Absolutely. Thank you very much. I think what we'll do is we'll go on to Khurram to do the next presentation. Ed, are you able to stay throughout for questions at the end?
Stick around. Yeah,
that's great. Thank you very much. So I'd like to introduce Khurram Khan. So Khurram works at North Mid. He's particularly interested in translational research, which is really interesting. And I know he's been active in our peer-reviewed journals around that. And he's also quite well known for banging the drum for experienced and junior doctors and how they're finding life. So that's much appreciated by us. Thanks very much. Khurram, we're going to let you introduce yourself in terms of what you want to talk about today, and then, as with Ed, we'll probably take questions at the end, depending on your availability, or we'll insert them in the middle, depending on how long we can have you for. Thanks very much.
Thank you very much, Claire. So can you see my slides actually?
I think they're just going to be brought up on the screen. Can't see them at this second. No.
No.
I think they're coming now. Thanks. Yeah. COVID-19, a tale of 2 pandemics. Yeah.
Yes, indeed.
Brilliant. Thank you.
Okay, so I think Ed has quite beautifully described every aspect of delayed diagnosis and the impact this pandemic had on cancer care. But I think frequently we forget about cancer itself, which I think is almost a pandemic with 1 in 2 incidents. So what we did actually was, next slide, please. So in this talk, what I would like to highlight is, firstly, the NICE guidance for chemotherapy and IOs, immunotherapy products, how this changed during the first and second wave. So what adjustments we had to make, and what impact it had on London Cancer Alliance, and then finally, what could be done to improve the cancer care. So personalized medicine, we talk a lot about it, obviously, but I'll briefly touch upon that shortly. What I think we can do differently, actually, to utilize to its best potential. So, in terms of the background, we are aware, so I'll not waste too much time on that. That's this whole pandemic started end of 2019, and within 3 months, it was obviously declared a pandemic, which actually it's a telling tale in itself, that the way it spread all over the world actually was quite dramatic. Now, the reason why cancer care was particularly affected was that there were data coming from China. Now, those days, a lot of papers came out actually with less stringent peer review process. So one of the initial papers from China, which described the general population who suffered from COVID, of those, actually small proportion of patients had cancer. And they drew conclusion that patients who had cancer had perhaps higher mortality. And of course, biologically, when you think about the cancer itself, as well as the treatment options that we have, particularly systemic therapy options, so indeed they have immunosuppressive effects. So as a result of this, there was a general notion that patients with cancer, whether they be on systemic therapies or not, they would be more susceptible to firstly contracting the virus, and secondly, in terms of having poor outcomes from the virus. So next slide, please. It should be the outcomes of 2019 novel coronavirus in patients. Sorry, I've lost the track of where we are with the slides, but this is, I think, the 4th slide. So we did actually a multi-center study to describe our experience in North London. Part of it is because in North Middlesex particularly, we saw a lot of patients presenting with, as you know, that was particularly one of the epicenters where there were a lot of patients who contracted the virus. So we, in a way, we were fortunate to have seen those patients early on during the pandemic. And we could see that actually the outcomes, in my personal experience as well, were not that adverse as we had anticipated. So next slide, please. So what we did was we collected data of all the patients in 4-5 different hospitals in North London who developed COVID positive disease and had background history of cancer. And then we compared their outcomes with their counterparts during the same time period who didn't have history of cancer but had developed or contracted COVID. And then we compared, so these were matched patients for age, gender, and comorbidity. So obviously it's a retrospective study, but we tried our best to reduce the biases within the study by matching the patients and making sure that they were from the same time period. So next slide, please. So in this study, we looked at various relevant factors like old age, comorbidities, and the cancer itself and their history of different treatments that they were on. And we looked at the 28 days outcomes actually from the COVID-19. Now at the time, actually, 28 days outcomes were not considered as a common endpoint, but thankfully now we see that actually this is considered as one of the important outcomes in terms of the adverse outcomes from the disease. So next slide, please, where it should show the study design. So you'll see that in order to power the study appropriately, we had cancer cohort patients from 5 institutes, and N was 30, so 30 patients. And then we screened a large number of patients, about 579 patients. And of those, we found that 272, so nearly 50% non-cancer patients who presented during the same time with COVID positive disease. And we selected 90 of them. So it was 1:3 actually proportion, again, to power the study better. And we looked at the outcomes, including time interval between most recent anti-cancer treatment and admission, And then the severe outcomes, including ITU admissions, requirement for ventilation and or death, and then indeed the mortality in these cohorts. So there is next slide on statistical considerations. So in the interest of time, I'll not read through it, but I think the main point to highlight is that we actually gave a careful consideration that the study was, despite small numbers, powered to estimate the differences in the outcomes, and a statistician was involved in that from the outset. So these are the patient characteristics. Sorry, it's the next slide actually. Should read the patient characteristics. So you can see that they were all completely matched group of patients, you know, age, gender, all matched, number of comorbidities matched. And when you see at the numerical data, you can see that there was no difference in terms of the median duration of hospital stay and the number of severe events, as well as the mortality. So death rate 37%. So 1/3 of the patients that's during the first peak died when they presented with COVID-19 disease, which is actually quite revealing. So, you know, these numbers are absolutely identical. And actually, when we published these data, we were further reassured that a bigger study actually after our publication came out as well from Birmingham group, which reproduced exactly the same findings. So next slide, please. So you'll see that we had different types of cancer patients. So it was, you can see the characteristics of the cancer patients. So actually all sorts of cancers, because there were small numbers, so we included every patient who presented during that time with history of cancer.
Cool. We've got about 5 minutes more for your talk, just to let you know. Thank you.
Okay, thank you. So just looking at the main outcomes again, so just, you know, that's the next slide, main outcomes slide. And you'll see no difference in the mortality, no difference in hospital stays, etc. So I think, I mean, despite the next slide, please, on discussion. So despite small numbers, retrospective nature of the study, and heterogeneity in the tumor types, we still concluded that we did not establish any significant association of adverse outcomes between cancer diagnosis and COVID-19. Next slide, please. I'll briefly touch upon the second study that we did. Obviously, so the first study reassured us that once you have you know, you have been on anti-cancer therapies and you present with COVID, the outcomes are perhaps not as bad as we anticipated. But of course, that left us with the second question. In fact, probably this should have been the first question, whether patients with COVID-19, whether patients who are on systemic therapies have higher risk of contracting the virus or not. And I'll go through these slides quickly in the interest of time. So next slide, please. So again, large number of patients at UCLH and North Middlesex who received chemotherapy during that time period. This is just to say that I think we were quite lucky, although we made some modifications in terms of the duration of chemotherapy and the types of chemotherapy during the first wave, but we caught up very quickly. And I have to say that during the last few months, actually, we are working to our 100% capacity, actually. So I can't recall any patients in last 6 to 8 months who've been denied chemotherapy when we thought they were suitable for chemotherapy or other systemic therapies. So this study is called Capital, and you can see that we screened nearly 3,000 patients, and of those 80 were excluded, but only 68 had COVID positive PCR test during that time. The rest were negative. So some straightforward conclusions. Next slide, please. So we ran a univariate regression analysis and looked at the associations in all the relevant ways that we could. So what we found was similar to what a lot of published data demonstrates. So there was an association with comorbidities in terms of the outcomes. So the more the number of comorbidities, the severe was the outcome actually. Male gender, it was well established at the time. Chemotherapy, actually high dose chemotherapy seemed to have an association, but generally we did not find, again, a strong association with the outcomes. However, the overall number of patients who developed COVID was about 2.3%, I think, which was slightly higher than the general population. However, one has to remember that at that time, general population was not offered tests, whilst the cancer patients had started having the test, which means that there was a stronger propensity to develop, to establish the diagnosis of COVID-19. So I think next slide, please, the capital results. And again, I've already said what the slide shows. It's a bit of a busy slide, but as I said, 2.4% patients developed COVID-19, but we didn't find a strong association with outcomes in this study as well. So please keep flicking the slides. You will find what this study adds. So I think what we, again, in this study, what we felt was the patients on systemic chemotherapy were slightly more likely to die if they contracted the virus, but it was not significant. And the type of anti-systemic treatment actually received by the cancer patients affect the likelihood of contracting the virus, but that was more associated with just high dose chemotherapy, mainly in lymphomas, etc. So what are the major challenges? That's the next slide. I mean, it's already been said how devastating the impact of COVID-19 on cancer care has been in the primary care in terms of diagnostic services. So of course there has been a significant reduction in the cancer referrals, and this actually equates to nearly 23,000 undiagnosed cases every week, which is a huge number actually, and obviously that will have an impact on the mortality. One has to remember that one of the most important features of BRC research over the last couple of years was that it was identified that in UK we were lacking behind in terms of early diagnosis actually, and this was one of the main themes where we were hoping to investigate, to invest and improvise and improve. I think final comment from me would be that we often talk about the personalized medicine, and we see it as a way of looking at molecular characteristics and tailoring the treatments accordingly. But I think we need to think a little bit outside the box and perhaps also consider that personalized medicine is not just about molecular features of the tumors, but it's more so about an individual patient, their needs, and taking into account their age, their comorbidities, and everything else to ensure that we optimize the care that we provide to our patients. And from the molecular point of view, we were quite lucky at UCLH that we had availability of liquid biopsies through Foundation Medicine panel during the last year or so, which helped us dramatically in terms of establishing the right treatment pathways for some of our patients who could have been offered targeted therapies instead of the systemic chemotherapies. So I think that's where I'll probably stop actually in the interest of time. I'm happy to take any questions. Thank you.
Thanks very much, Khurram. So I'm having a look at the questions. Those will probably come in as we go through. I haven't got anything specific yet for you, Khurram. So I think what we'll do is move straight to Manish Chand, who's our last speaker. So Manish is a colorectal surgeon, and he's particularly keen on laparoscopic surgery, I know. Manish, I can't see that he's on the screen. If you want to, that's hi Manish, hello. I think I'm going to let you introduce yourself. Thanks so very much for coming. And in terms of time, it's probably if we could stick to somewhere between 10 to 15 minutes, that would be great. Thanks very much. Brilliant. If we can share Manish's slide. Are you okay with that, Manish? Yeah.
Yep. That should be on now. Okay.
Thanks.
Thank you very much, Claire, and thank you for the great talks beforehand by Ed and Khurram. I'm going to give you a bit of light-hearted relief at the end of the afternoon, just before afternoon clinic, and talk about robotic surgery, what we're doing now, and perhaps what to expect in the future. Unfortunately, for some of you, I'm one of these futurists, and often get carried away and excited by various technological innovations. So anyway, look, when we think about mankind, it's really since the period of the Renaissance that we've seen automation, mechanization, industrialization, and that really changed the way that our species behaved. and of course the innovation that brought. With that, robotics has certainly been something in various industries over the last 100 years that has led to greater efficiency, change in working practice. And these are some of the fictional robots that perhaps we've all come across through movies over the years. And what do they all have in common? Well, apart from being clearly very colourful characters, they often are able to do things autonomously. So they're able to move, often think, and certainly execute tasks without the formal instructions of their human masters. But what does the word robot mean? Well, if we look back in the history of the actual phrase, most account it from this Czech playwright. And the word robota comes from to be in bondage or to be in slavery. So when we think of robots, and certainly when we think of robots in surgery, it is often one of this master-slave system. And this is what we have. So this is the latest generation surgical robot by a company called Intuitive Surgical, and it's the Da Vinci robot, perhaps named after its Vitruvian Man picture and several arms on this particular machine. But it's not a true robot. It is what's known as a telemanipulator, which basically means a human being controls everything it does. It cannot move on its own. It cannot think on its own. None of those arms work on their own. It has to be driven up to the patient by one of the theatre staff members. It then has to be docked by several theatre staff members, and then a surgeon sitting at a console remote to it will be able to use it. So it's really not robotic surgery. It's sort of a fancy instrumentation or fancy laparoscopic surgery. And the reality is the robots that we do have, well, there's lack of affordable robots. That thing costs about £2 million, costs about £250,000 a year to service. It's not autonomous. Very few people are trained to use them. And there's a general lack of technical expertise, because if we bring these things in too quickly, then unfortunately patients get harmed. So there needs to be governance around it. So that's all the bad news, but there is opportunity, and perhaps as we come out of the pandemic and certainly learn to change our practices, there is opportunity to change. And this is a quote that I've given for I suppose this is more of a quote for non-medics and often a sort of funding quote, that no surgeon ever works at 100% efficiency every single time they walk into the operating room. And perhaps that's where AI and robotics can bridge that gap between a ruthlessly efficient machine and man who often has deficiencies of some sort, or mankind that often has deficiencies of some sort. And perhaps AI and robotics is where we will be able to enhance and augment our practice rather than think of it substituting us as surgeons and clinicians. So how does our practice need to change? We need to clearly become more efficient. We've seen lots and lots of waste that has been improved as we've been forced into certain practices in the last 12 months. We certainly need to be more precise in our approach in surgery and also in the diagnostics. And Ed has shown how we can be more precise in who gets a colonoscopy and when they get a colonoscopy. And that will no doubt help resource allocation. And overall, what we want to do is reduce risk for patients. So often when you try and introduce a new technology, particularly into an established department, there are barriers of adoption. And the kind of questions that get asked are, does this actually fulfill a need? Is it going to make things more tricky and difficult and slow me down? I can do 6 open anterior sections in a morning, but I don't want to waste the whole day doing it precisely with a robot. Is it too expensive? And then does technology make our interaction with patients impersonal? Well, this is the sort of adoption curve or cycle that we have when we bring things in, and it takes a long time, 10 to 20 years. And it does so because we want to bring it in safely and accumulate enough evidence and data to say that we can do this for all of the right reasons and have less criticism when we bring in these expensive technologies. Because we need to move faster. I mean, if you look back 25, 30 years, none of these things existed. Imagine a world without YouTube, Google, iPads, iPods. It seems unfathomable. But we all remember doing our O-levels and our GCSEs handwritten. Very few of us would have had computers, and if you did, you had a word processor or a typewriter. It is a completely different world now due to technology, but healthcare hasn't moved at the same pace. So specifically to rectal cancer surgery, and that's probably what I'm most known for. I mean, I do some of the highest volume of colorectal cancer surgery in London, certainly, but across the UK. And we need to think of clever and innovative, but safe and effective and financially viable ways of doing difficult pelvic surgery, which will be successful both for the patient, but also successful for the institution. So at the moment, the difficulty is when you've got a cancer that's very close to the anus, you might leave some tumor or some of the fat around the tumor behind. And in this particular paper by some colleagues of mine from Belgium, in up to a third of patients, if you MRI them after a rectal cancer operation, you've actually left some of the mesorectum, some of the fatty tissue that contains the nodes behind, and that's really worrying. And we do that because the surgery is really quite difficult to do, open or even laparoscopic. So there is a need to develop the correct instruments to do this. But unfortunately, there are so many different ways of doing this. There is no universally accepted way of doing it. And this is a paper I wrote with the head of colorectal surgery at Cleveland Clinic, that which technique should we really be using for these patients? So this is a kind of theatre setup that one would have in a robotic operation. The multicolored, multi-armed robot is at the top right of the screen. It gets docked on one side of the patient. There are still scrub assistants and possibly even a surgical assistant. And then the surgeon sits remotely away from the console. It's got wires connecting everything, but we try and do it via Bluetooth now rather than wires. And this is sort of what it looks like. So surgeon sitting away in a console, bit like those old arcade machines, and using these interesting finger grips to do the surgery, while the robot's arms move at your command. And this is sort of what it looks like on the inside. And these arms are able to move very precisely. There is clarity, exceptional clarity and high definition of the picture. There is no shaky movement of the assistant. And you can then look at these important structures, and I'm not going to go into the details of what necessarily the anatomical structures are, but there are important nerves that you don't want to damage, important vessels down there. And when you can see clearly, you can do things more effectively and more precisely. And this is the type of surgery that I'm trying to bring in across our network. So what does the evidence say? Well, the evidence suggests that if you do this in high volumes, you can reach good financial costs, which means that if you're doing over 200, 250 cases a year in your unit, you are on parity at least with laparoscopy, and perhaps even bring those costs down because you get more efficient. You use less equipment, patients go back to theatre for complications less, you need less blood transfusion, less ITU resources, and overall you develop a slick pathway which not only gets patients through the surgery effectively and safely, but it also means that you have a better patient flow through the hospital. Unfortunately, the only randomized controlled trial is against robotic surgery, saying that actually it didn't prove to be a major benefit, but that trial was run over a decade ago, and there were some difficulties in the trial design. So I think it's about time we had better, more up-to-date evidence, because certainly the current high-volume surgeons would testify that it is a safe, effective, and financially viable technique. So as I move to the end of the presentation, this is what we're going to have as we move on with digital and precise robotic surgery. Standardized ways of doing things so that we all do the same thing in the same way and we can measure our outcomes. Using fluorescence and other factors to be able to see beyond white light. So using special dyes to highlight cancer, highlight anatomy, highlight physiological process to make things more efficient, use intraoperative navigation and imaging so that we can precisely home in on what we need to do, and then the use of performance analytics and AI. And I'll whiz through in 10 seconds the last few slides, just for the purposes of time, just so you can see some pretty pictures. I won't show any more video footage in case those of you are having lunch. But in effect, this is the kind of thing that we can look forward to, not in the too distant future, operating with a pair of HoloLens on and trying to look through human anatomy. And this is a very slick marketing video of a surgeon using HoloLens, but to prove that it can be done, this is me doing it in theatres at UCLH and using a pre-made image from the patient's MRI scans to then superimpose before I start operating. And I think I'll probably leave it there.
That's great. Thanks very much, Manish. I think we will have to have you back just to show us a lot of pictures in the future. That's really good. Okay. That was really good. We've tried today to give a kind of spread of the kind of work that's going on locally, which is just truly fantastic and world leading. In terms of questions, I think I want just to. I'm going to verbalise one of the main questions that's come in, which is around, because what we're doing is gathering themes, is around family history. So the question was, I think probably to Ed, but anyone can chip in, can an asymptomatic patient with a strong family history of colon cancer requesting a colonoscopy be reassured by a normal fit, or should we refer anyway? So I presume that's a symptomless patient just asking about their family history. Ed.
So I did a brief reply. There are national guidelines, so it really depends on how strong the family history is. And if they've got a single relative aged under 50, then that would qualify you for a colonoscopy, but at age 55, or if you had 2 first-degree relatives of any age. That said, fit is probably useful in this situation, but it's not been trialed as such, so the data isn't there. It should probably work, but there are national guidelines. The British Society of Gastroenterology, BSG, you can look it up, or you can ping me in advice and guidance, and I'm happy to go through it.
That's really helpful. Thank you. Thanks very much. I guess advice and guidance would obviously allow us to give a bit more particular detail about the patient concern, so that might be probably better. Yeah. And as you've mentioned advice and guidance, I just want to remind all of you that there's a new little box on advice and guidance which you can tick, which gives permission for the consultant who's reviewing the advice and guidance to upgrade the referral to upgrade the advice query to a referral. So that's a new little bit of really useful magic we've added to advice and guidance, which I think clinicians will find really helpful. I'm just having a check of the questions. I think, hopefully soon self-operating programmed AI for the Earth will be found before operating in Mars from Earth. What do you think about that comment? Yeah, hopefully. Okay, I want to say thanks very much to everybody for joining today, and I can see that we'll have to absolutely definitely have a follow-up for this, which we'll try to do, and we need to talk about Mars as well, and perhaps the galaxy. Would you manage that, Manish, for us, as well as some pretty pictures? And what we want to do is probably take some of that robotic stuff, some of that imaging, and see if we could use it in primary care. I think that'd be great, being able to look inside someone when they're sitting next to me.
Well, what I would say, Claire, I think some of the things that I did skip out, and I think Ed would also testify, is that we do use artificial intelligence programs on our colonoscopies, for example. Yeah. And what I was going to show is how we can detect polyps, how we can characterize polyps through it. So it's not something necessarily for the future. It's here. It's here. OK, well, then we definitely need it in primary care too. What do you think? Yeah, I think something. OK, so thanks very much to all of you. Some of you have popped the speakers put their emails on the slides. You'll be able to access that, having a look at the recording if you like. And if you need to make any direct contacts and can't find those again, then if you contact us through the directly, we'll try to make that happen. Thanks very much.
and I'm going to close today. Thank you. Let everyone go back to the rest of their day jobs. Thanks very much. Bye-bye.